This unit is the first on various cardiovascular disorders. We are first going to start with a review of blood pressure. Blood pressure is defined as the force exerted by blood against the inner walls of blood vessels. Arterial blood pressure rises and falls in a pattern that corresponds to the phases of the cardiac cycle. We will be reviewing the cardiac cycle in a later unit. Systolic pressure, this is the higher of the two numbers of blood pressure, represents the maximum pressure achieved during a ventricular contraction. As the ventricles contract, they force the blood into the pulmonary trunk and aorta, and this increases their pressure. Diastolic pressure represents the lowest pressure that remains in the arteries before the next ventricular contraction. As the ventricles relax, arterial pressure decreases. Pulse represents the alternate expanding and recoiling of the arterial wall as blood moves through. There are various factors that will influence our blood pressure. The first is heart action. The heart produces blood pressure and determines how much blood will enter the arterioles when the ventricles contract. Some terms associated with heart action include stroke volume. This is the volume of blood that leaves the ventricles with each contraction. On average, this is roughly 70 milliliters of blood. Cardiac output represents the volume of blood leaving the ventricle every minute. It can be calculated by multiplying the stroke volume times the heart rate. Normal stroke volume of around 70 milliliters and a normal resting heart rate of 70 beats per minute brings a cardiac output of almost 5 liters of blood circulating every single minute. Blood pressure varies with cardiac output. If either the stroke volume or the heart rate increases, cardiac output will increase, and so will the blood pressure. Blood volume also affects blood pressure. This is the sum of blood cells and plasma volume in the vascular system. If blood volume increases, blood pressure will increase. It is also related to cardiac output. If stroke volume or heart rate increase, the blood volume in the arterial system increases. An increase in cardiac output will be registered as an increase in the systolic pressure. An increase in the force of ventricular contraction will also be registered as an increase in the systolic number. Peripheral resistance also affects blood pressure. This is the force produced due to friction between blood and the walls of the blood vessels. This friction will slow down blood flow. To keep blood flowing, a force must be generated to overcome this friction, and this is blood pressure. Whatever affects peripheral resistance will affect blood pressure. An increase in peripheral resistance is registered as an increase in the diastolic pressure. Lastly, viscosity will affect blood pressure. Viscosity is thickness. It is related to how easily particles flow. The more cells and plasma proteins that are present in the blood, the thicker the blood will be. Increased viscosity means more resistance and more force needed to move it, hence an increase in blood pressure. This is showing how each of these different factors will have an effect on blood pressure. To maintain normal arterial pressure involves regulating both cardiac output and peripheral resistance. To control cardiac output or regulate cardiac output, this is done via both mechanical and neural regulation. Mechanical factors involve the Starling's law of the heart. This is the relationship between the length of myocardial fibers in the ventricular wall and the force of contraction. As the fibers of the ventricular wall are stretched, this means that a greater amount of blood is entering the heart, and the heart has to deal with a greater volume. This will result in a greater force of contraction. This ensures that any extra blood that enters the heart will be released. Neural regulation is the result of receptors in the wall of the aortic arch and the carotid sinuses. These are known as baroreceptors. They send impulses to the cardiac control center of the medulla. Any increase in pressure on these receptors will result in impulses being sent that will decrease the heart rate and as a result decrease cardiac output and decreased blood pressure. A drop in pressure results in impulses being sent to increase the heart rate, increase cardiac output, and ultimately increase the blood pressure. These impulses act on the SA node of the heart. Peripheral resistance is regulated by changes in the diameter of the arterioles. There's another control center called the vasomotor center in the medulla. This keeps the muscles in the blood vessel walls in a state of tonic contraction due to sympathetic impulses that it sends. This means that the blood vessels remain at a diameter somewhat in the middle. They are not at their maximum size and they are not at their minimum size. They remain in the middle. This allows them to be sensitive to changes in blood pressure and can either increase or decrease their peripheral resistance by an increase or decrease in sympathetic impulses. So the blood pressure is rising, an impulse can be sent, causing the diameter of the vessel to increase. Larger diameter, easier for blood to flow through, and this will decrease the blood pressure. This again is the same flow chart, but adding how peripheral resistance is controlled. The main disorder we're going to look at in this unit is arterial sclerosis. In these conditions, the arterial walls undergo changes that reduce their normal flexibility and elasticity. This process is referred to as sclerosis or hardening. There are 3 forms. Each is based on the type of artery involved and the differences of changes within the wall. In other words, which layer of the wall of the vessel is affected. The first of these is medial calcific sclerosis. This is a relatively rare form and it is idiopathic. This typically affects the medium-sized arteries found in the limbs and the genitalia, particularly in people over the age of 50. The layer of the vessel that's involved is the tunica media. The muscle tissue in the tunica media begins to degrade. As a result, you will see calcification of the tunica media in the area where the muscles have degenerated. These calcium deposition or deposits are palpable, especially in the superficial vessels, and they can be felt as hard spots. There will be no narrowing of the lumen. Basically, the calcium is just replacing the muscle one-to-one. So because there's no narrowing of the lumen, there's no clinical disease. The second form is arteriolosclerosis. This affects the fine arteries and arterioles. The layer of the vessel is both the tunica intima and the media. Both layers become thickened by deposits of plasma proteins, lipids, and an increased thickness of the basement membrane. This is often described as hyaline arteriolosclerosis due to the uniform glass-like appearance of the deposited material. Ischemia will develop downstream as the vessel wall thickens. This condition is common in the elderly and diabetic patients, and it is also seen in association with systemic hypertension. The big one is atherosclerosis. This is a very common form. This is the underlying disease process in most coronary artery disease that results in myocardial infarctions and also cerebrovascular accidents. This form affects the larger arteries, especially the aorta and its branches. It will produce characteristic lesions known as erythematous plaques or erythroma. These are deposits of lipid, connective tissue, and proliferating cells in the tunica intima that result in focal hardening. Initially, the plaques are scattered, but later they begin to merge and become more extensive. As they enlarge, they begin to protrude into the lumen, restricting the size. How does this disease develop? Early warning signs can be seen in the tunica intima as early as a 1-year-old child. These will show up as narrow yellow streaks running longitudinally along the intima of the aorta. This is primarily due to focal proliferation of smooth muscle cells in the tunica intima. These are known as myointimal cells. Muscle cells are normally in the media. That is the main composition of the tunica media. The tunica intima should not have muscle cells. These cells are called myointimal, myo for muscle, intimal for the fact that they are in the tunica intima. You will also see small cytoplasmic globules of fat in these cells. Minimum elevation of the endothelial surface will be seen at this time. Then, for about the next 10 years, fatty streaks will continue to form. By the age of 10, roughly 10% of the aorta's surface is streaked. In underdeveloped countries, these streaks become either static or regress. However, in developed countries, these streaks will continue to develop. Arthrogenesis refers to the process of plaque development. After the age of 10, new streaks form and usually become plaques by the age of 30. These represent a buildup of macrophages and myointimal cells in the tunica intima. You will also see the development of foam cells. This represents the accumulation of fat in the cytoplasm of these cells, and this accumulation of fat will give the cells a bubbly appearance. As the number of foam cells increase, the intima becomes even thicker. Over time, a fibrous cap will form. This represents proliferating smooth muscle cells plus fibrous connective tissue cap. This is showing the process. Here's the endothelial lining. This is the tunica intima and the tunica media. You see an increased access of monocytes into the tunica intima that become macrophages. Muscle cells gain access and they become the myointimal cells. Both of these cells begin to scavenge the lipids, the LDLs, that also are gaining access to this layer, and they become foam cells. As the foam cells accumulate, this creates that fatty streak and also begins to increase the thickening of that layer. Over time, these plaques can become complicated, result in various complicated lesions. Wall damage will be seen. The damage to the wall could be due to dystrophic calcification. This is deposits of calcium salts in the tunica media. You could also see hemorrhaging of the plaque. What happens as the plaque grows, the vessel is going to try to revascularize this plaque, grow new blood vessels through the plaque. This response is coming from the vasa vasorum within the vessel. Basically, it's trying to grow new vessels to ensure nutrient supply within this new tissue. This process is usually unsuccessful and typically results in hemorrhaging. You will begin to see medial destruction. This occurs as the fibrous cap enlarges and reduces the ability of oxygen and nutrients from getting into the tunica media. This will result in further weakening of the arterial wall. This is showing how these plaques grow and the consequences of a complicated erythroma. And another problem is that the endothelial surface will also become affected. As the intima becomes soft, over time the intima will become soft and necrotic, and the endothelial cells will lose their support. They will become damaged or stripped away, and now this ends up exposing the plaque to the flow of the blood. In this picture, you can see how big the plaque is. The normal size or lumen should be out here where this darker pink ring is. All of this area here, you can see the high concentration of foam cells, and this is how small the lumen has become as a result of this plaque. How do these erythromas form? Nobody is really 100% sure, but one hypothesis is known as the response to injury, that these begin to form following some type of initial injury to the arterial endothelium. We know from our past units that mild injury can result in an increase in permeability. This will result in the increased access of lipids to the tunica intima. Also, as a result of injury, the endothelial cells begin to retract. This too will allow an increased access of lipids into the tunica intima as well as the monocytes. Remember that the monocytes then develop into macrophages, and they will begin to phagocytize or engulf all of these lipids and ultimately become foam cells. When there is injury, growth factors will be released by the platelets and macrophages. This is what results in the cell proliferation and further adds to the development of the erythroma. These growth factors also lure in more monocytes to the site of damage. They promote mitosis of the smooth muscle cells to increase their numbers, and also the monocytes will secrete other agents that will further damage the endothelium. So this is showing how minor injury to the endothelial surface will increase the permeability, allowing increased access of the lipids, alter the surface so platelets adhere and monocytes adhere, and then move in to become macrophages. So this is just flow chart of what we talked about. Next, we're going to look at some of the risk factors involved in developing atherosclerosis. The primary risk factor is hyperlipidemia. This is elevated levels of fat in the blood. With atherosclerosis, we are concerned primarily with plasma cholesterol and triglycerides. When lipids are transported in the blood, remember lipids are not soluble in water, and the main component of plasma is water. So these lipids have to take on a specific shape, and they are also combined with protein, so they become a lipoprotein. This makes them more soluble, and it also helps with the cellular uptake. These phospholipids around the cholesterol, you will find phospholipids arranged so that the phosphate heads, which are the water-soluble portion, arranged all around the outside. The lipid tails, which are insoluble, are pointed more toward the center. Then a protein portion is added called an apoprotein. This is what allows the lipid to recognize cell membrane receptors of cells that need this cholesterol and will aid in the transport of this material across the cell membrane. This is showing the process. The cholesterol are represented by these small circles. Over here we see an LDL, a cluster of cholesterol surrounded by phospholipids, and this is the apoprotein portion. Here is the membrane of a cell that needs cholesterol. It will have receptors for that apoprotein. So this LDL will bind to the receptor, the cell will take in that LDL and then metabolize it and break it down, getting the cholesterol it needs. With atherosclerosis, we need to look at the plasma levels of both LDL and HDL. These function in cholesterol transport between the liver and other tissues that metabolize the cholesterol. 70% of plasma cholesterol is carried in the form of LDL. Cells that need cholesterol will have receptors for LDL. The problem is that LDLs may also be taken up by the arterial endothelial cells. They only begin to take up LDLs in large amounts when there is excess LDLs. They take up the leftover LDLs that the cells that need the cholesterol don't take. Cholesterol will then begin to accumulate in the walls of the blood vessels and will be scavenged by the macrophages and the smooth muscle cells. Any cholesterol that is not utilized should be carried away in the form of HDLs to the liver. This is where it will be metabolized or lost in the intestines. So HDLs help to clear the cholesterol out and prevent erythroma formation. As the levels of LDLs increase, so does one's risk of a myocardial infarction due to atherosclerosis. As the level of HDLs increase, the risk of a myocardial infarction decrease. An increase in LDLs may result in a greater amount of cholesterol deposited in the intima. Again, the more cholesterol, residual cholesterol that cells don't use, the more of it there is around, the better chances it has of being scavenged by the tunica intima. Increased LDLs can also promote platelet and macrophage adherence to the endothelia, and they may increase the uptake of cholesterol by the endothelial, and this may make them more susceptible to injury. This is just summarizing the various types of plasma lipoproteins. This flowchart is showing the normal pathways for plasma lipid transport in the body and how it is typically cleared out and managed. A second risk factor for atherosclerosis is genetics. There is no real recognizable pattern of inheritance. Here, it may be due to genetically determined susceptibility or due to shared lifestyles, or it could be due to a genetic inheritance of another risk factor, such as hypertension. One truly genetic disease is familial hypercholesterolemia. This is a relatively rare cause of atherosclerosis. It is due to a defective LDL receptors. As a result, less LDLs can be taken up normally into the tissues that need the cholesterol. As a result, LDL levels remain high in the plasma, and as a result, you will see an accelerated development of atherosclerosis. These people will be treated by trying to decrease their dietary intake of cholesterol, as well as by using drugs to decrease the LDL levels in the plasma. Basically, what these drugs do is they bind to the cholesterol in the intestines and prevent its absorption. Another risk factor is hemodynamic stress. This refers to the wear and tear of the endothelium subjected to the rapid arterial blood flow. This hemodynamic stress could be due to surging blood as it expands and contracts the wall with each contraction. It is also due to stress that is caused by a rapidly moving blood column splitting at an arterial branch point. This will create turbulence that can then damage the endothelium. It may also be due to systemic hypertension. Hypertension results in an increase in blood pressure. Higher blood pressure means an increase in stress and various factors that will also cause damage to the endothelia. Inadequate exercise could also be what it's due to. Sedentary people tend to have higher resting heart rates than active people, and this can result in stress. This is showing the turbulence that is generated when blood reaches a split in an arterial vessel. Another risk factor is smoking. Smoking leads to an increased chance of coronary thrombosis and myocardial infarction. Acute MIs are more likely to be fatal in smokers versus non-smokers. Half of all heart disease in women has been attributed to smoking. The risk for developing these is due not only to smoking itself, but also due to passive or secondhand smoke. The mechanism as to how smoking contributes to atherosclerosis is unclear. What we do know is that the endothelial lining becomes damaged due to the hypoxia associated with smoking. The carbon monoxide in smoke replaces oxygen in hemoglobin, so that less oxygen is being carried to the tissues. This results in hypoxia. This hypoxia will promote smooth muscle proliferation and the accumulation of LDLs in the tunica intima. Another factor is that nicotine has a vasoconstrictive effect. This too results in hypoxia, as well as causing direct damage to the endothelium. And lastly, smoke promotes platelet aggregation. This will result in an increased release of growth factors and a risk of thrombosis. Other risk factors include age and sex. As we age, so too does our risk of atherosclerosis increase. Intimal thickening and sclerosis are normal parts of the aging process. Combine this with other risk factors, and this can lead to an even faster development of atherosclerosis. Also, males are generally at a greater risk than females. This is due to normally higher levels of LDLs and lower HDLs in males compared to females. Diabetes mellitus is another risk factor. This results in early and severe atherosclerosis, and the problem is the higher levels of glucose in the plasma. This enhances the addition of sugar to the plasma proteins as well as to the LDLs. This process is known as glycation. Glycated LDLs, think of them as sugar-coated LDLs, may be more aggressively scavenged by the macrophages. Then there are various miscellaneous factors. Physical activity. Sedentary people tend to be at a greater risk. They have shown that an increase in exercise helps to decrease the blood pressure, increase plasma HDLs, and lower plasma cholesterol, triglycerides, and LDLs. Increased exercise also leads to a decrease in platelet aggregation and an increased ability to get oxygen from the blood into the tissues. Obesity is another miscellaneous factor. The link is indirect, and it may be tied to other risk factors that go along with obesity. Stress, there is a link, but not 100% sure of the mechanism. We know that stress does increase blood pressure, and higher blood pressure is higher hemodynamic stress. Alcohol. Moderate amounts of alcohol have been shown to increase HDLs. but high amounts of alcohol or no alcohol at all have been shown to decrease the levels of HDLs, and we're unsure as to why this happens. This is a flow chart of the various risk factors and how they contribute to the development of atherosclerosis. Next, we look at some of the consequences of atherosclerosis. One problem is that no sign or symptoms develop until well-advanced plaques are formed. Then you will see the narrowing of the lumen and deterioration of the tunica media, and these lead to other consequences. You'll see the greatest effect in the iliac and femoral veins of the legs. This is due to arterial stenosis, or narrowing. This narrowing will reduce the blood volume delivered downstream. In the femoral and iliac veins, wounds will begin to heal slower. Skin wounds may ulcerate, leading to an increased risk of infection and development of gangrene. Narrowing of the coronary and cerebral arteries can result in chronic ischemia in the brain or the heart, resulting in slow, progressive loss of functioning. This can result in memory loss and confusion when it affects the brain, or chest pain at low levels of activity in the heart. Renal arteries are another vessel that can become stenotic. This will result in ischemia or less oxygen delivery to the kidneys. This will activate the renin-angiotensin system. This system results in fluid retention and vasoconstriction. Vasoconstriction will lead to hypertension, and this just aggravates or increases the progression of atherosclerosis. So as hypertension, it increases atherosclerosis, which creates even more hypertension. Another consequence is thrombosis and embolism. These complicate the problems, especially in the coronary and cerebral vessels. Now, how does atherosclerosis contribute to a thrombus? Atherosclerosis protrudes into the normal blood flow. This creates irregular and turbulent flow. Advanced atherosclerosis produces irregular surfaces on the lumen. This will then allow for platelets to adhere. Thrombi, if they form, narrow the lumen even more, and as the process continues, this lumen may become completely occluded. This can lead to either cerebral infarction or myocardial infarction. Now, how does atherosclerosis contribute to an embolism? Large complicated plaques begin to have the ability to release necrotic debris into the blood. These will travel through the blood and end up occluding smaller vessels. If it's in the peripheral circulation, this can cause problems as well as possible occlusion of the smaller vessels of the brain. Another consequence are aneurysms. This is a focal dilation of a blood vessel wall. Most arise in the aorta and its branches due to atherosclerotic damage. There are three basic types. Fusiform is very symmetrical, and it looks like a spindle. Saccular is asymmetric and bulging. And then berries are small saccular aneurysm that tend to affect primarily the cerebral vessels. This is just a picture illustrating the fusiform, the spindle shape, saccular, protruding, and then the smaller berries. Consequences of an aneurysm. One is a thrombus. They interrupt the normal blood flow, creating turbulence. They can end up releasing thromboemboli that can then occlude other smaller vessels. These aneurysms, this expanded wall of the aneurysm will apply pulsating pressure to adjacent structures, for example, the brain or the heart. This may cause these structures to atrophy or to weaken. And another problem is that the vessel can rupture. This bulging wall weakens over time. High arterial pressure will then drive the blood into the adjacent tissues. If this is around the heart or the brain, this can become fatal. Another problem with an aneurysm is when it becomes a dissecting aneurysm. The tunica media over time becomes weakened, and the tunica intima becomes torn away. This results in blood passing through the intima and into the media, where its pulsing force separates or dissects the medial layers. Consequences of this, can result in downstream ischemia, as more blood is trapped in this occlusion, and less is getting to the tissues that need it. Also, the wall can rupture. Cardiac tamponade, for example, is when the aortic wall ruptures near its base and blood becomes trapped in the pericardium. This too may be fatal. And it can also result in disruption of the aortic valve. And this is showing a dissecting aneurysm. The next disorder is systemic hypertension. This is elevated blood pressure in the systemic arterial system. This is based on a diastolic pressure of greater than 90 millimeters of mercury or a systolic pressure greater than 140. New measures are trying to reduce these numbers to 85 for the diastolic number and 135 for the systolic number. Looking at incidence patterns and essential hypertension. In most cases, no cause can be identified. This is known as primary or essential hypertension, i.e. no cause. It is felt to be due to some, in quotes, defect in a control mechanism of the systemic blood pressure. Possible speculations are these three that are listed. One, it could be a genetic defect in the kidney's sodium excretion mechanisms. If the kidneys cannot excrete sodium, this will begin to build up, which causes an increase in extracellular volume as water is retained. More volume means a greater cardiac output. Greater cardiac output means a higher blood pressure. It could be a genetic defect in the membranes of the arterial smooth muscles. Any increased sodium in the serum will result in longer periods of retaining calcium in the smooth muscle cells. This will then result in an increased level of contraction for any given stimulus, causing an increase in the systemic blood pressure. It could also be due to a genetic defect that involves an increased responsiveness of the autonomic nervous system. As a result, they will have exaggerated constriction input to the systemic arterioles. This may be the link between stress and hypertension. Under stress or increased stress results in an increased activation of the autonomic nervous system, an increased release in epinephrine, and this can cause the high blood pressure. Secondary hypertension accounts for 5 to 10% of all the cases of hypertension. Here, secondary, it is some other disorder that is the cause of the elevated blood pressure. You have some other disorder, and as a result, secondarily to that, you end up with hypertension. This could be due to damage to the renal tissue that reduces blood flow to the nephrons. When the nephrons aren't getting adequate blood flow, this will activate the renin-angiotensin system. This involves the production of angiotensin II, which is a very potent vasoconstrictor. The system also stimulates the secretion of aldosterone, and we know that aldosterone increases sodium retention as well as water retention. It could be due to renovascular hypertension, where you get activation of the renin-angiotensin system when a normal functioning kidney is supplied by a diseased or stenotic renal artery. This too results in, as a result of the stenotic artery, there is decreased renal blood flow, and this is what activates the renin-angiotensin system. It may also be due to an excessive secretion of other hormones. Aldosterone, we know the effect there. Birth control users. In 5% of birth control users, hypertension is a problem. What happens is that estrogen causes the liver to increase its production of the precursors of the renin-angiotensin system. And then other hormones, the glucocorticoids as well, can result in hypertension. There are two forms of hypertension, benign versus malignant. Benign is a slowly progressive increase in pressure over time. Malignant is a rapidly progressive increase. This will promote endothelial damage in the small arterioles, resulting in microthrombi. It can also result in damaging the red blood cells and causes microangiopathic hemolytic anemia. The malignant form can also result in hyperplastic arteriolosclerosis, where you see an increase in smooth muscle and endothelial proliferation. The consequences of hypertension: development of arteriolosclerosis, You can see damage to the central nervous system. Chronic high pressure can directly and indirectly result in neurological problems. Plus, hypertension predisposes one to the development of atherosclerosis. The last disorder is thrombophlebitis. This is venous inflammation following thrombus. This condition is very common in the deep leg veins. This could be due to a focal infection within the legs, disruption of the normal blood flow in the leg veins, or a hypercoagulation state. For example, the person may be dehydrated and see an increase in red blood cells or an increase in platelets. The results, the primary concern is the risk of possible pulmonary embolism as pieces of these thrombi break apart. You will also see pain, lots of pain, due to the reduced venous drainage and inflammation. Who is at risk? Anybody who is inactive, for example, post-surgical patients. Also childbirth, especially when women spend a long period of time with their legs up in the stirrups. And smokers are at a greater risk of thrombophlebitis.